surgery and urology. And he'll be taking us through his journeys, adventures, both professionally and life adventures as well. He's very sports addicted. So let's hear him. Thank you, sir.
I hope everyone can hear me loud and clear. My name is Devesh Misra. I've been a consultant pediatric surgeon at the Royal London Hospital since 1995. And about a year ago, I got appointed to be a chief editor of this very prestigious academic book, textbook of esophageal surgery, Atresia. I'll repeat, textbook of esophageal Atresia. And we managed to get some of the biggest names from around the world to contribute to this book. So in many ways, it was almost as if my whole life was leading up to this book. How did this book come about? It's not moving forward, the next slide. Apologies, there's always some technical glitch, but here we are back on action. So how did this book come about? As you well know, in esophageal atresia, the standard leak rate is anywhere from, say, 5% to 16%, and the standard stricture rate is anywhere from 40 to 72%. In my own lifetime series, it showed that my leak rate was down to 0%. I've in fact never had a leak, and the stricture rate was 20%. Possibly this is a world first, and I was invited by one of the important American associations to be chief editor of this book. But we may have jumped the gun a little. Let's go back in time. How did my journey start? It is a pleasure always to come back to AIIMS. 1978, age 16, I got selected to join the undergraduate MBBS program. And there was a major hitch. I was only 16 years old. And administration said, you cannot join up. So in many ways, my journey was almost truncated before it had begun. Luckily, they put me in touch with Professor Guleria. As you well know, Professor Guleria unfortunately died very recently. He was, I think, the dean or the sub-dean then. He was a very kind man, listened to me and my father, put forward our case, and said, well, we'll break the rules for you. So age 16, I stepped into the payload atmosphere. So I did my MBBS here. I did 3 years of general surgery here. And then I did pediatric surgery here. A tribute to the training I received here, that by the time I had left the shores of India, I had done 8 OA tops as a first surgeon. And I'm hoping that the same trend must be continuing even now. If many people ask me what was the atmosphere like in AIIMS, I would have to say that it was intellectually fierce. You could challenge your professors from the first year of residency, and they certainly challenged you right back. So the knowledge flowed back and forth very nicely. Some of you may remember these names. M.M. Kapoor was my professor in Unit 3. Samira Nandi, the famous GI surgeon, still going strong, and Professor Aikit Havan. In pediatric surgery, we had Dr. Rothgi, Viresh Bhatnagar, D.K. Gupta as my consultant trainers. Dr. Rothgi was quite a strong personality. She could do craniosynostosis and she could do malrotation. So it was a very exciting department to be in. Not just general surgeons and pediatric surgeons. We imbibed a lot from some excellent faculty around us. There was P.N. Tandon, the giant of neurosurgery, L.K. Bhutani, the very suave dermatologist, K.S. Reddy, cardiology. And of course, in pediatrics, we had O.P. Ghai and Mehrbaan Singh, whose books are read even today. Just a brief glimpse into what I look like as an intern. I think I look like a math year tutor. And every time I used to come back, Professor Kapoor is no more with us. I would always take my children to visit him, and that's Professor M.M. Kapoor, I think about 10 years ago. So with that excellent training that I received from AIIMS, I reached the UK in 1992, and I asked, what's the average age to be a consultant pediatric surgeon here? And they said for the local UK-wide graduates, it would be about 41, so for you it would be a little bit more. I was not prepared for that, and with the support of some of the biggest names in UK, at age 33, I was appointed to the Royal London Hospital as a consultant, and the Royal College of Surgeons sent me a letter saying I was the youngest consultant ever appointed. And then started a very grueling journey where I had to learn new skills. And I talk about sailing, and yes, sailing has been a very major passion in my life. And scuba diving. Here you see me scuba diving with reef sharks, but more of that later. I hope to, time permitting, show some videos. So coming back to OA talk, I'll spend about 10-15 minutes giving an introduction. As we've already mentioned, back then in 95 and for many, many years after that, people accepted these complication rates to be the norm. And in 1995, there were 2 or 3 dogmas that prevailed. The number one, it was that the lower esophageal pouch has segmental blood supply, and you did not mobilize it because the lower pouch would turn ischemic. Number 2, the esophageal anastomosis was done as you see it here. You divided the fistula almost transversely, made an identical cut in the upper pouch, and just anastomosed it like that. And to my mind, the patient had a stricture even before he had left the OR. There's a lot of confusion about how much you should mobilize the upper pouch. Back in the 90s, there were 2 consecutive editions of Robin Smith, which said 2 entirely different things. One edition said that you should mobilize the upper pouch only as much as is required, otherwise you get trachomalacia. But another gentleman felt that no, you should mobilize it all the way to the root of the neck to rule out any silent upper pouch fistula. Personally, I go about halfway up. So coming to my innovations in brief, the details you find in the book when it comes out next month, hopefully. But in brief, right from 1995, I started mobilizing the lower pouch as much as was required. It has always been my belief that esophageal ends that lie comfortably together are less likely to stenose and less likely to leak. And back in 95, I didn't need optical magnification, but I just put on loops on one occasion. And I found that actually the intramural blood supply of the esophageal pouch is quite good. And more importantly, when a bit cheekily I cut the so-called adhesions or attachments of the lower pouch, I could not see any bleeding or oozing. So right from 1995, I have not believed in this dogma that the lower pouch has segmental blood supply that you should not cut. I always mobilized it as much as was required. The second thing that I did was I used to make a tiny cut, a slit in the lower pouch. And therefore, I could make the slit in the upper pouch also a little bit longer. So this diagram shows bay in the upper row, and lower down, I know there's a bit of artistic liberty shown. It's shown a bit exaggerated, but making the small cut in the lower pouch and making a slightly longer cut in the upper pouch, you get a much wider anastomosis. Now, in 2005, when in APS I presented my work, I still remember Keith Ashraf, who was the giant in those days, one of the world's biggest names then, of pediatric esophageal surgery. He actually a little bit dismissively called it the Misra cut. And there was Jay Grossfeld there also sitting on the panel. And people were not supportive of the idea. So I don't mind it. They were reflecting the thinking of that time. They said this so-called cut can distort the local anatomy and perhaps is not required. I must say I was a little bit depressed. I went into a shell, continued with my sailing, scuba diving. It's almost like 2 years later that I thought, no, actually, I should have explained myself better. And I sent them both an email, Jay Grossfeld and Keith Ashraf. And I said, look, if the circumference of the lower pouch is only 1 centimeter, then forget a 4 millimeter cut. Even a 2 millimeter cut increases the circumference by 2 to 4 millimeter. That's a 40% increase. And after that, more and more people started coming around to my way of thinking. The third innovation that I used to do was I found that there is a no man's land where the tracheoesophageal fistula meets the trachea. It's a very poor quality tissue with attenuated muscle. And I thought I'm taking to this lower pouch to up to meet a well vascularized, muscularized upper pouch. It didn't make sense. So if the gap wasn't too much, and I have to emphasize, you don't excise 2 or 3 millimeters if there's going to be a problem with mobilization on the gap. If the gap wasn't too much, I have always removed 2 or 3 millimeter off the distal esophageal pouch. And I think when you anastomose good quality tissue to good quality tissue, you get better results. But that time, as you can see at the bottom of the slide, that concept in particular was considered heresy, and I did get a lot of criticism. Now, to just jump the gun, my lifetime work has been presented at many places. I've never had a leak. My stricture rate is only 20%, and it has remained constant right from 1995. More importantly, none of my patients needed more than 5 esophageal dilations. And we have analyzed our own department figures, which are no different from Great Ormond Street or anywhere else. There are some patients even go on to get 10 dilations. So the feeling was that A, I was getting fewer strictures, but B, they were less severe and therefore needed fewer dilations. I've always been very self-critical. It is possible that these good results are a result of my innovations. It could be my skills and experience, but I'm always humble enough to say, maybe I got lucky. But I also say that if it wasn't luck, then it's important to share my experience so that others can start using some of these innovations or all of these innovations and see whether they can bring down their complication rate. And now more and more of the world is accepting my innovations. In fact, in this book, I've got a hearty endorsement as a commentary from Steve Rothenberg, who, as I'm sure you know, is the world's best known name for thoracoscopic esophageal atresia repair. And Darek Petkovsky is perhaps the second best known name after Steve Rothenberg. And I was delighted when a few months ago he sent me an email saying he was doing a live workshop somewhere, and to the global audience, he said, what I'm going to do now is the so-called Misra cut. It does bring down the stricture rate. So I'm very, very pleased that more and more people around the world are following some of my ideas. There are many authors in this book, and the beautiful lady you see here, I have a lot of respect for her. She has excellent academic energy. This photograph is from 10 years ago. And one of the authors in the book is Shilpa Sharma, who's a professor here at the All India Institute. She has a formidable international reputation, a big name in colorectal surgery, and was also very active in the European network. To the other gentleman in the photograph is my former trainer, Dr. D.K. Gupta. There are many authors other than the UK in this book. Sean St. Peter, I'm sure you're all aware, is the chief editor of the best-selling book on pediatric surgery. There's Warwick Teague from Melbourne, Tom Hamilton from CHOP, Philadelphia, and of course Ravi Kanodia from PGI. He's quite a legend now himself in thoracoscopic work. And it was nice to get all these best-known centers, Harvard, Toronto, Washington, on board so that I could tap into the institutional protocols and enrich the book. No book in the UK can be written unless you have some authors from Great Ormond Street. And on the left, you see Paolo Di Coppe. He's a legend in pediatric surgery research. He's the professor there. And he wrote a very important chapter on aortopexy. This book came about because, as I had mentioned before, Mridula Rohtgi, the dashing Biresh Bhatnagar, D.K. Gupta, inspired me in AIIMS. And later on in 1994, my final year of training, these three gentlemen at Great Ormond Street were my mentors. It was a very lovely atmosphere then. In the photograph on the left, you see Professor Lewis Pitts. And in fact, the photograph is from 2 months ago. He's about 85 years old, not in great health, but he was a giant of a man then. And on the right, you see my mentors, David Drake and Ed Kyle. My oldest patient with OA-TOF is now 30 years old. And to write this book, I went and actually traced all my adult patients. And it was very telling to see that some of them were still having problems. And there's a lot of interest in this, that we need to follow up our patients into adult life so that you know what should be the protocols to hand over to the adult gastroenterologist. The chapter on long-term outcomes has been written by Sean St. Peters, an excellent chapter, where he has covered the risk of malignancy, Barrett's epithelium, and what should be the surveillance protocols later on. How often should you do endoscopies, biopsies later? One chapter in the book is devoted to notable cases. Now, I know that if you have a very tiny baby with a OA top, the traditional wisdom is you just ligate the fistula if you have to, and then do a delayed primary repair weeks later when the baby is a lot bigger. But as we mentioned in the book, we actually at the Royal London Hospital operated on two 500-gram babies. I'm honest enough to say my own patient died of cardiac causes a week later, but my junior colleague Ashwini Joshi, this case report is actually published in BMJ. She operated, did a primary repair, and the patient is very well. Paulo Di Coppi also operated on a baby who was only 660 grams. There are many other notable cases in that chapter. And this was the patient we were talking about, the 500-grammer, who has made a good recovery. There are some learning disabilities, but that is quite common in babies who are born at 500 grams. And it is always a pleasure when you appoint your former trainee to the faculty position alongside you. And this is the lady who had operated on that child, Ashwini Joshi. It's a pleasure to see her grow and mature and develop exquisite surgical skills. There has been validation from all parts of the world. Over the last 30 years, I've trained more than 125 registrars and fellows, and they are now professors and consultants all the way from USA, EU, India, down to Australia. And about 20 years ago, I had given a talk about my innovations in China. That was a massive meeting. I was very pleased that some of the people came and spoke to me afterwards. And a few years later, I was not surprised when one of those centers published their work. This is published in Journal of Pediatric Surgery. And as you can see in the diagram on the lower right, they've shown the Misra cut. So more and more people around the world are using it. There are some other minor things that I will talk about. I won't go into details and bore you. You're all very trained, experienced pediatric surgeons, but I never put in chest drains. There were times when we did put in a chest drain. That was because, say, maybe the anastomosis was under tension and I thought it was rupture. I always put in a TAT tube when I start feeding, always at 48 hours. I don't believe in contrast studies. Now, in my series, some patients did have contrast studies. They were sort of patients who were considered to be difficult, but overall, 80% of my patients have not had a contrast study. And then I start oral feeds on day 7. Yes, if you're not using a chest drain, immediate post-operative chest X-ray to serve as a baseline is important. This has been standard practice for 30 years, that if the anastomosis is under tension, then you paralyze and ventilate for 5 days. But I'm a bit of a restless surgeon, and I started asking the question, why not paralyze and ventilate some patients for 2 or 3 days? I have not been brave enough to do that. I'll leave it to the next generation to conduct the trial and see whether you need paralysis and ventilation for 5 days, or you could get away with 3 days. The reason why we wrote the book is that in the last 10, 15 years, we have seen increasing complications with OHR, and these complications are surgical, anesthetic, and even neonatal. And there are many reasons for that. We are coming across, I do a lot of medical legal work in the UK, and I'm coming across a lot of injuries to the azygos, aorta, trachea, right bronchus, who are nervous, and for many years as a consultant, need heavy support and complex surgeries like OHR. Just a brief mention, the azygos vein often gets taken for granted. You don't have to ligate it or divide it if you don't want to, but a lot of people do it. This diagram is from a textbook, and it shows diathermy usage on the azygos, which always leaves me very nervous. And I mention that because in my career of 30 years, I've been called into theatre on 3 occasions when my younger colleagues had a massive blowout from the azygos vein, and therefore I always say treat this vein with a lot of respect, because in one particular case we had 2 blood volumes lost, and that patient in fact had a cerebral infarct. Because essentially when the azygos medial ligature slips, it's almost like it's the right atria which is back bleeding into the thorax. And this is something, there are lots of very didactic things which I, from my experience, have taught. Some of you may get bored when I say it, but I've repeated at many parts in the book. Every suture, whether esophageal, tracheal, or vascular, both things are important. See it tighter, feel it tighter. Give respect to every suture, you'll have less blowouts, you'll have less leaks. Of course, when you open the chest, you look at the diagram, it looks so crystal clear, everything is color-coded, but in real life, it looks something like this. And therefore, identification of both pouches is vital. And in the book, I've pointed out that identifying the lower pouch is very important. You divide the zygus, there it is below. Spot the vagus nerve, and it should be running along the esophagus. There's the typical muscular appearance of the lower pouch and the so-called anesthetic whoosh. You ask the anesthetist to stop ventilating, then ask them to handbag the patient, one big whoosh, and you see the fistula fill up. But at the bottom of the slide is something that I've never read anywhere in any journal or book, and I put it down. This is my own personal feeling. Sometimes you do get lost, and if you're doing a OA talk, God forbid, around midnight, you're not very alert. Knowing all these tips helps. So imagine if you can't find the lower pouch, no big deal. Finding the upper pouch is always easy. Find the upper pouch, take a double bite through it, and then in your mind's eye, draw an imaginary line from the upper pouch going down at the same depth. It's important, at the same depth, and you should find it. If you get lost finding the lower pouch, you've gone too deep. Remember, in that part of the chest, if you're 1 centimeter off, it's almost like being in a different pin code or zip code. Identifying the upper pouch, we all know it. Push on the replogal, the anesthetist does it. And once you identify both pouches, stay close to your area of interest. The right-sided arch. There's a lot of talk about doing echocardiography to identify it. I think there's a huge error rate in echocardiography. And personally, whether it's the arches on the left or right side, I've always done a right thoracotomy throughout my career, and most of the experts who have written chapters in my book concur. So it's left side arch or right side arch, we always do a right thoracotomy. I think I'll skip this slide. We're running a little bit out of time. Okay. And on one case, I was called into the anesthetic room. The anesthetist was administering anesthesia. Patient had a cardiac arrest, and she asked me to do the cardiac massage while she did the rest. I just observed a massive hump in the epigastrium, and I realized that was a massive stomach. The ventilation had caused an acute gastric dilatation, cut off the venous return from the vena cava, and all I had to do was forget cardiac massage. I just took a Venplon, plunged it into the epigastrium, deflated the massive stomach, and the patient lived. And in fact, it was very nice when they were being discharged from their 16th birthday. The parents of the patient told their child about that episode, which they so far had never done. So there are many such interesting anecdotes in this book for you to read and hopefully learn from. I will take a break now. I could talk of many other things like megarectum, megalourethra, urethral fistulae. I've published extensive series on that, but I'll speak now about my other passions in life. And one of them is scuba diving. Scuba diving, either you can go out in a boat and go out to a coral reef, or like you see here, this is the El Fanar coral reef in Sharm el Sheikh. It's a vertical drop, goes down a giddy 100 feet. You have to be an advanced diver to do it. And you literally step off the stairs and you start going down. In this photograph, you see a gentleman on my right. He's wearing what looks like an armor of a Rajput warrior. And I wonder whether anybody can guess why he's wearing this armor. The answer is that this was back in 2012. Feeding sharks and then going down to dive with them. And I'm talking about reef sharks, I'm not talking about great whites. That time was considered very dangerous. In fact, we had to fill out a form saying, if we come back without a limb or we come back without dead or whatever, nobody's responsible. So the whole idea is this person, we lower a lot of shark food on the ocean floor, and this person goes down with the steel armor and he feeds all the sharks. And when the sharks stop feeding, then you know they are contented and hopefully you are safe. That's the theory. You can see what happened here. The photograph is not very great, but a couple of sharks came late to the party and were very angry. They had not been fed. And as you can see, one of them jammed into this guy who had the steel armor. No lasting damage other than his pride was very badly hurt. And this I call my life's best ever photograph. I'm giving the thumbs up, but if I check my heart rate, then it would have been 160. Because these reef sharks, they are contented, swimming all around you, and we had a professional photographer to take videos and photographs. Like I said, there is the theory and there's the practice. And one of these sharks was a bit on the larger side. I'm not sure if it was a dusky, but it came very close and gave me a nudge. And I can tell you, when a shark this side gives you a nudge, it hurts. So in this photograph, you can see that I'm almost falling backwards. And all I could do was concentrate that I can keep my regulator in my mouth and my weights from belt from falling off. Luckily, no lasting damage other than the fact that my tummy hurt for a few days. So that was one of my life's best experiences, diving with reef sharks. That's the Atlantic Trench near Bahamas. My scuba diving has taken me all around the world, and one of the most beautiful experiences you can have is diving down what are known as blue holes. So these blue holes are almost like vertical shafts which go down and down. I'm an advanced diver, so I'm only allowed to go down to 100 feet, but there are some other people who go dive down further. When you're doing a deep dive, you often take nitrox with you. Sometimes on your journeys, you come across some beautiful. These are normally, they avoid humans, but this is a hammerhead shark. And mercifully for us, hammerhead sharks don't usually attack. Don't usually, they do not attack humans. It's got a great range because its eyes are sitting out there on these cephalofoils, and therefore it has one of the rare fishes or sharks which has 360-degree vision. On one occasion, I was diving with my junior doctors, and sometimes things don't quite go according to plan. So this was in Malta, which is one of the scuba diving capitals of the world, and we were meant to go through a tunnel. So you have to have advanced buoyancy skills. You go through a tunnel till you reach this huge underwater cave. Now, these fishes have never seen light, so they look different, they have different physiology. Now, the story is that as we have a dive master in front of us, but this dive master was a bit dour. He wasn't looking after us. He was a very powerful swimmer, so he just swam off like a fish, and we couldn't even see him. Halfway in the tunnel, I felt the lady behind me tugging at me. And that's when I had a bit of a panic attack, because although I'm an advanced diver, I realized in the confined spaces of that tunnel, I could not turn myself around and help her. And I must confess, a bit of a panic attack. It's not nice to admit, but I did have a panic attack. Somehow I fought free of the tugs and then raced to the cavern, came here, found the dive master, David, and you can't talk down there. So we just were talking with sign language, and I said, trouble in the tunnel. But there was no trouble. The two ladies came through, and we said this, because this is the signal for everything all right. You don't show the thumbs up signal. Thumbs up signal in scuba diving means you want to go up. And the ladies did this. So we didn't understand. Okay, everything is fine. We finished our dives, came back through the tunnel, back on the boat, and the first thing I said was, Clara, why did you tug me in the tunnel? And I was shocked when she said, I didn't tug you. And I don't know if any of you have guessed the reason why. I had got caught against a ledge. So my buoyancy skills were not that good. And I think when things like that happen, scuba diving is a dangerous sport. I don't want to put off anyone from scuba diving. What I do is extremely adventurous. You can do safe coral diving, and I've taken my children to Andaman and Nicobar Islands. It's actually quite safe there. But on that day, I did have a reality check. My buoyancy skills are not great, and I may have drifted up and my cylinder had caught the ledge, and I thought someone was tugging at me, while in reality, I was showing poor skills. So after that, go back, do another advanced course, get your buoyancy skills back in action. And that's my family. Those are my children. We are a scuba diving family. And this was, I think, in Maldives. A very small anecdote, a funny anecdote. You can see at the top of the photograph, there are 3 dark blobs. That's the diving instructor with my 2 children. So they were getting the diving instructions out there. I obviously was getting bored. So I was sitting around on this beach, Whale Shark Island, Marmagili. And suddenly this bunch of 10 beautiful ladies came there, and there was a lot of noise, and they asked me to take their photograph. And then one of them said, why don't you take, can we have a selfie with you? So I just made the joke. I said, if you guess which country I'm from, I'll take a selfie. And then in that part of the world, people say Turkey, Morocco, southern Italy. And I said, no, India. And they said, no, 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 you don't look like the usual Indians. Because most of the Indians who are working there are from South India. They're a bit darker skin. So I was trying to tell them that people from the north are a little bit more pale skinned. And don't ask me why I said, do you watch Hindi film? They said, yes. I said, don't you see Ranbir Kapoor? He's a bit pale skinned. Hi, Thichan, welcome to the, you missed a cheeky anecdote. And I said, haven't you seen Hindi films? Ranbir Kapoor, he's a bit pale skinned. And then the lady said something which my family laughs about till this day. The lady said, oh, yes, you do look like Ranbir Kapoor. And my children almost died laughing that night. They said, yes, Dad, the only resemblance is both of you have 2 eyes, 2 ears, and so on. But I'm glad that for 1 millisecond on Whale Shark Island, Mamagili, I was a micro-celebrity. Moving on to sailing, and I'll show you a video first. It's not coming up. Sorry, you missed it, so we'll start again. Okay, I hope you enjoyed that. So now I'll move on to the talk again. So the video you saw was from my 50th birthday. That was the last time we took only 2 people to a boat. Then we realized that we are all getting on in years. None of us are very fit. And now we have a rule that we have at least 3 or 4 people, because when you're sailing, if things go wrong, you do need more hands on deck. So I usually say, I did own a yacht for many years, but when COVID happened, I panicked and I sold it. So my yacht was a 44-foot Bavaria. It has a mainsail and a front sail, and at the stern, at the back, you have the wheel for navigation. And I've done some racing in my life, and as you can see, when you sail into the wind and the winds are a bit fierce, the yacht starts tilting, and you can tell by the angle with the horizon. Whenever the sailing winds are calmer, it's always nice to get some education. Sailing, scuba diving is a little bit like surgery. You have to do CME all your life. So here with the yacht master, I'm practicing my knotting skills, because when you anchor, when you moor up, it's important to tie the yacht to the marina, to the side of the water carefully, and that's where the practicing of knots comes in. On one occasion, I sailed with ladies only, and the lady you see on the left in the green t-shirt, she was an expert sailor, 10 times better than I. It was a great experience to challenge myself. That particular occasion, the yacht was a 55-footer, and the reason why I'm standing up like that, as we are slowly moving up to the buoy, you have to be able to see above the bow, and therefore you stand up and manage the wheel with one hand, and the other person is also there to help you. So you adjust according to the size of the boat. One of the beautiful things about sailing is you're entirely on your own. Wherever you want, you drop anchor, have a swim, have a lunch, and move on. But like I said, this is that same trip. The winds can suddenly turn fierce. This is a week-long sailing. And one day we ran into a storm, and it was a little bit tricky. Often my children pull my leg. How come we've never seen photographs or videos of the storm? Well, the truth of the matter is you're just struggling to stay alive. But there's one photograph I took at the end. As you can see, we were a bit battered, but we sailed through the storm. There's a lot of exercises you have to do while you're sailing. And one of the exercises is going up the mast so that you can do some repairs, change the flag, get a better view of something else. And that was my friend going up. You take a lot of care and attention. You go up in a harness, but you also have an additional rope to make sure that if one rope breaks or slips, the other rope keeps you alive. I've done a lot of night sailing, and as you can see, this is at the end of a very difficult night. My face is totally battered. And sometimes I used to think, I'm a surgeon, I wake up at night anyway, and here I am sailing, and I'm also waking up at night. So sometimes you get the feeling it's not a lot of fun, but it's a grueling exercise. It teaches you a lot. And this is the Straits of Gibraltar. This is the second busiest shipping strait in the world. Your yacht is like a matchbox compared to the big steamers and ships that go past you. You have to be very alert. So in the daytime, it looks like this, very relaxed. You can see everything. And that was the beginning of the night sail. All of us are a little bit tense. Very rarely you hear of mishaps. So yes, night sailing is a little bit tricky. But why do we do it? Because at 5 a.m., the sun just came out. I'm sure all of you are aware. Sunsets take their own time. You have 10, 15 minutes, take a lot of photographs. Sunrises, sometimes 1 or 2 minutes only. And when the sun came up, I just told my mate, Tony, just grab the camera and go click, click, click. And I rate this. The best photograph in my life was the diving with sharks, and this is my second best. I treasure this photograph. There is a dark side to sailing, and as many of you know, I've had a bad back for 30, 35 years. It's something I was born with, and every now and then it gives me very severe back pain. So 10 minutes after that lovely photograph, I was there on the deck, and after that I had to take a lot of painkillers, baclofen, etc. But my message to the youngsters is it does not matter what health ailments you have. Be active, pursue your passions, and I've certainly not let my bad back deter me from sailing, diving, and a lot else. And of course, that's my daughter there in the middle. When I take my family out, it's always safe daytime sailing. For some reason, my children are not much into sailing or scuba diving. I guess they saw their father doing it, and therefore it was no big deal to them. But I've spent all my life sailing. We have a great bunch of sailing friends. When the winds are not strong, there's a lot of conversation and a lot of bonhomie on the deck. There are different kinds of sailboats. Here, what we were talking about was monohull. This is a catamaran, so it has 2 hulls on either side. It's also much smaller and therefore much sharper. You have to be very quick when you respond to wind changes. I've never stopped learning. On my 60th birthday, here I am learning how to do stand-up paddleboarding. I've also done a lot of canoeing in my life. And on one occasion, we were meant to go to Galapagos. And the currents there are difficult, and I was told to do the advanced certification in canoeing. I was able to do everything except for the Eskimo rule. Now, for those of you who do not know the Eskimo rule, it is that you are the single person in a canoe. You append yourself, so you are sort of facing upside down in the water. You use the oar, push against the swimming pool floor, and correct yourself. I could do that stage. But the second stage, without which you don't get the advanced certification, is you go towards the deep end of the pool. Now you append yourself, and using the oar, pushing it against the water, you try and correct yourself. For some reason, I used to panic. After a while, water used to enter my nose, and I was never able to do that module, and therefore, the trip to Galapagos never happened. A few years ago, about 10 years ago, I learned surfing, and that's my son. Whenever we can, we try to go down to Cornwall and do it. A lot of people ask, how did this love for adventure sports come into it? The credit goes to my father, who you see here. He was in the Air Force. This photograph is from 1965. He got so bored he was a lawyer, he got so bored of his desk job that he decided that he's going to become a paratrooper. When he became a paratrooper, he wanted more adventure. The instructor said, you can parachute into the sea. And my father said, I don't know how to swim. But this was the Air Force. So the instructor just said, learn. 2 years later, that's my father. He had learned swimming and he had parachuted into the sea. I've also done a lot of windsurfing, and the reason I showed this photograph, my children were 9 and 8 when I taught them windsurfing. So start your children young. And back in London, in their school, they created a sensation because they were the only children in the class who knew a bit of windsurfing. And here we are, this is a lake in Austria, where the winds are much calmer, and therefore it's easier to learn windsurfing. My other passion is golfing. And as you can see here, this is New Year's Day. We should be in our bed, but 9 a.m., I and my best friend, Chris, the gynecologist, we are out there, and you can see a lot of frost around us, and I think we were the only 2 people on the golf course that day. On another day, frozen lake. It doesn't matter when if the temperature drops to -2. We are always out and about, and that's my message to everyone. Be active, be fit. And yes, I taught my children young, and we are a golfing family. Wherever we go for holidays, we try and find out if there's some sailing nearby, some golfing nearby. There was, for many, many years, a lecture I used to give here in AIIMS to the undergraduates. I haven't been back for a while, and it was life beyond medicine. And I always used to tell people, you may not have some of these facilities in India, but when I was in India, when I was in AIIMS, we used to do a lot of trekking. And I still remember 1981 trekking to base camp Kanchenjunga. Back in 81, people had not heard of Sikkim. So trekking all the way to base camp Kanchenjunga was a great experience. And I would strongly recommend medicine, surgery. It's a very tough life, a lot of stress, a lot of health issues. So make sure you have a life beyond medicine. It need not be sports, could be music, painting. Do cultivate your other side. So I'll take a break now, and I'll say, how much time do we have, Shilpa? Okay. If anyone wants to ask questions, please feel free to put something on the text. Now, very briefly, we have 10 minutes. I'll speak about 1 or 2 things. So as you know, one of the common complications following proximal hypospadia surgery is megalourethra or urethroceal. It's a very difficult condition to treat because the first patient I inherited in 95 was from my senior. He had operated on a urethroceal, it fell apart, and the patient had 3 fistulae, and the family was very unhappy. So I started right from 95 doing urethroceal a bit differently. I can call it an inversion technique or a plication technique, and believe you me, it does work. It's a rare surgery to do, so I won't claim that I have the world's largest series or whatever. So here you see a patient who has had a hypospadia operated a few years ago, and now has a urethroceal, a bulge in the urethra. If it's smaller than that, I would not operate because, as you know, surgery does have its own complications, but he was getting a lot of dysuria. So we decided to operate, and this is how I do it. I inject lignocaine with adrenaline, and because the border between the thinned out skin and the thinned out urethroceal is sometimes just a millimeter or 2 thick, so I inject some fluid into that space, preferably with adrenaline, and very carefully make this incision. Your heart is in your mouth when you're doing the surgery. You make that incision, and then you start dissecting out the urethroceal from the skin all around. And here you see it. The urethroceal has been dissected out. And if you do it in the traditional way, near the shaft of the penis, you excise it, but then you run the risk of urethral fistula. So this is how I do it. I just take a mosquito forceps, an artery forceps, depress the urethroceal, and in the first instance, just take 2 stitches of proline on either side and start irritating. As time goes on, you give more and more layers, and then you think you've done a good job. But I always insist, put a syringe or nozzle into the tip of the penis and inject some saline with the tunica at the base, and you suddenly realize, actually, there's a bit of bulge at the bottom. So you start plicating it a bit more. In effect, you're burying the urethroceal over and over again. And what you see here, it looks like a very good result. But when we did that saline injection test again, now you can see a faint pulse, not at the bottom, but at the top. So you repair it some more, and that is your finished result. So I recommend it to you. This is a rare complication of proximal hypospadias, megalourethra or urethroceal. I have never had to resect. You can always do it by plication. The complications will come down. Obviously, I forgot to mention one small thing. Whenever you're doing the surgery at the top end, you can see a pretty good-sized urethral dilator. One of the reasons for a megalourethra or urethroceal may be urethral stenosis, so make sure that the glands have takes a good sized urethral dilator. So that's how a urethral seal looks when it's finished. And now very briefly in the end, just a few minutes. I have always collected data prospectively. That book on esophageal atresia and this paper on urethral fistula, I could not have written if I was not collecting data prospectively on all my index cases right from 1995. Believe you me, there is no hospital data system in the world which can accurately get you back all your patients. So just a brief review of my 30-year experience. Every year, there are lots of papers which are published on hyperplasia, but not many on fistula repair. And this is Tony Rickwood from Alderhay, a man I used to respect hugely, very honest. And he had published his own series of urethral fistula repair. And as you can see, an honest man, he even reported that one child was cured at the 6th attempt. In my particular series, the fistulae were mainly proximal penile, and I do think that proximal hypospadias is a different animal from distal hypospadias. Proximal hypospadias, the tissues are very undervirilized, paper thin, and complicated high. So I'm not surprised that in my 30-year hypospadia series, more fistulae were seen proximally. But yes, some were seen in the midpenile area and some coronal. This is the kind of patient I'm talking about when you have proximal hypospadias, where the meatus is almost next to the anus, the penis is very poor quality, and not surprisingly, proximal hypospadia patients do get more fistula. Another example of a patient who almost looked like a hypertrophic clitoris when he was born. And another reason why we sometimes get fistulae, some patients with proximal hypospadias in particular get BXO, and that can complicate life for you. Sometimes you have to excise all of it, put in grafts, and start all over again. This is the kind of patient I see in my private practice, operated multiple times elsewhere. And by the time they come to you, multiple fistulae, very poor quality tissue. And it is a challenge to operate on these patients. So this was the paper I recommend to you. This was published in PSI, Pediatric Surgery International, in 2022. That time it was a review of a 24-year review of my patients with very long follow-up. The techniques that I have emphasized, described in that paper are a first string closure, which perhaps had never been described before I popularized it, or offsetting the skin suture line and then anchoring it to the butt fascia. At the bottom, everyone knows this, you use non-overlapping skin suture line. But the most important thing is the first string closure. So just to explain it, this is a traditional fistula. You close it in the standard way, skin closure, urethral closure, and some soft tissue layers in the middle. You will have a recurrence in a few patients. However, I know it's a little bit of artistic liberty taken here, but look at this. You take a first string suture. When you tie the knot, you reduce the weak area from a line to a dot. And that is the reason why the first string suture has worked so well in my hand. The second modification that I used to do was, after I've closed the urethral fistula, doesn't matter what technique, I used to take the skin across and anchor it to the butt fascia. Because I think sometimes the skin just slides back and you get recurrences, but if you anchor it to the butt fascia, hopefully it stays there. And the same, if you close the fistula transversely, you can still supplement it by anchoring it to the butt fascia. This I'm sure everyone knows. Try and keep your suture lines at right angles to each other if you're not doing the first string, with the skin suture and the urethral closure is at right angles to each other. And then, therefore, theoretically, the weak point is only at the intersection. Just a couple of photographs to show you. The first string fistula works only when it's 4 millimeters or less. So here is a small fistula in the subcoronal area, and we've taken a first string, and now what is being shown at the top of the slide is tiny waterproofing flaps, because sometimes in redo surgery you don't have a lot of redundant tissue, and you put it on top. When you raise other waterproofing flaps, be careful to raise it with scissors rather than a knife, because when you use a knife, you are a little too thorough. And as you can see on the left, the skin fold is already looking quite dusty and battered, so you have to be careful. Take enough waterproofing flap without killing off the skin. And in my 24-year review, I think this is the last slide, so thank you for bearing with me. In my 24-year review, I've never had more than 62 patients who had fistulae anyway. So 62 patients had 73 fistulae. And I had once chaired a session in SICKITS Toronto, and they are not fond of the idea of spontaneous resolution, and they believe it does not work. And my series, I was quite surprised myself. It was only when we collected all the data we realized that 9.6% of our patients, the fistula resolved spontaneously, either after a single dilation or without a dilation. So I recommend it to you. Don't be in a rush to close tiny fistula. These are my results at the bottom. Cure after the first attempt was very high with the first closure, 93%, and following a linear closure, it was 70%. But as we showed in our paper, no patient in our massive series of 24 years ever needed more than 2 attempts for cure, and that I've been told by the observers also. We also found that we have analyzed proximal fistulae occurring in proximal hypospadias versus fistulae occurring in distal hypospadias. And I say they're almost like two separate diseases, because fistulae in proximal hypospadias are more likely to be multiple, more likely to be larger, and the recurrence rate is high. And the reason for that is that the penis is under-virilized, poor quality skin, and therefore in proximal hypospadias I treat it with a lot of respect and try and bury the fistula closure under as many layers, sometimes using tunica vaginalis transcription. In proximal hypospadia surgery, yes, you close the fistula, but you may also have to do other procedures alongside. You may have to do a bit of urological advancement, treat the stenosis, you may have to do some redo chordy correction. And if the penoscrotal transposition wasn't corrected fully initially, you correct it later. So in conclusion, fistulae following repair of scrotal hypospadias are very taxing. We believe when we published it, we were the first people in the world to look at fistulae in that setting. My very strong recommendation for the burst ring suture, it reduces the weak area to a dot, and like I've said before, no patient in our series needed more than 2 attempts. And I think that's the end of the talk. I kept it very informal, showed a bit of esophageal atresia surgery, showed you a bit of sading and scuba diving, came back to hypospadias. I hope you all enjoyed it. And lastly, I have to thank Shilpa once again. Shilpa and Srinivas, thank you very much for giving me this opportunity.
Thank you. That was an awesome talk. We'll take questions. I'll request Dr. Tichin, Dr. Ramesh, and Dr. Malli to please moderate. Please come in front. Dr. Ramesh, we'll start with your comments on esophageal atresia and low birth weight babies. You see a lot of cardiac anomalies. So what is your suggestion for cardiac anomalies with esophageal atresia in the Indian setting? Which major and which minor cardiac anomalies? How should we go about that? You can switch on the mic.
Presentation. I was interested in when you, of course, we do operate or we do have kids with cardiac anomalies. Associated esophageal anomalies do come as syndromic approaches, and the lower pouch that you showed and the anastomosis which you have developed, do you see associated tracheomalacia along with these babies, in these babies? Because what we often find is that along with the cardiac anomalies, there will be airway anomalies, and esophageal atresias are rare in the patient group that we operate or we see. Of course, they have short esophagus, fistulous connections, but blind pouches and their anastomosis are rare. So I was interested in knowing how many do you see with associated tracheomalacia or stridor in the postoperative phase?
Yes, so as we all know, tracheomalacia is part and parcel of follow-up of esophageal atresia. A lot of our patients with OA top anyway have the so-called top cough, the barking cough, and that's tracheomalacia. The chapter on tracheomalacia and eutropexy has been written in my book by Professor Paolo Di Coppe, who's a world authority on it. And in fact, there, a lot of the bronchoscopy is done by the pediatric ENT people. So they have a very sophisticated, what they call an airway team. Patients are evaluated, all kinds of sophisticated imaging studies are done, bronchoscopy, etc. And then they decide which patients need surgery. The ones who need surgery, they do aortopexy then. But we have also covered in our book this recent revolution where I think it was the Utrecht group which started it to say, can we avoid tracheomalacia in the future? And they are conducting a global randomized trial. I don't have the details, but they are going to do prophylactic primary tracheopexy. So take stitches from the posterior wall of the trachea to the prevertebral fascia. And I guess it will be a few years down the line when you randomize patients and find out whether the patients who've had a tracheopexy, whether they needed an aortopexy ever or not. So that's to answer your question about tracheomalacia. Now to answer your question about cardiac anomalies, the chapter on that has been written by Philip Kuchera. You may or may not know him. He's one of the world authorities. He's a pediatric cardiologist. So at the Royal London Hospital, we are handicapped by the fact that we don't have pediatric cardiac surgery. So we have to very carefully triage our patients. If an OA-TOF patient has a cardiac anomaly, we have a very good early conversation with Philip Kuchera and his team. All the neonatologists at our center at the Royal London Hospital are trained in echocardiography anyway. So we have echocardiography and that the patient is born, and the very next day we get a cardiac echo done. And then a conversation starts with Philip Kuchera and team at Great Ormond Street. There are some patients with mild cardiac disease, and those we are able to do our OA-TOF and then get the cardiologists and cardiac surgeons involved. But if they've got tetralogy of Fallot or something very major, if they're duct dependent, then the cardiologists at Great Ormond Street will say, do not do the OA-TOF at the Royal London Hospital, send the patient to us. So sometimes the cardiac surgery takes precedence.
Thank you. Online, we have Professor Kanishka Das, professor from AIIMS Bhubaneswar. Sir, you're online. We can hear you.
Thank you, Shilpa. Dr. Devesh, it was great listening to your talk. And you have really lived life on the edge, as I can see, with so many passions that you pursue relentlessly.
Thank you.
Well, my congratulations on that. I think you had left by the time I joined at AIIMS, 95 to 98, but I've heard a lot about you. My question to you is about the technique of first ring suture for the fistula. Very often we find that the rim around is quite fibrotic, and in other methods we remove that and try to get together supple tissue. So do you think this first ring works? It stays in that fibrotic edge there?
Yes, so I covered it so briefly, I didn't have time to go into the details. And the golden rule is whether you're dealing with that atretic lower esophageal pouch or you're dealing with the urethral fistula, if you've got fibrotic tissue, remove it. So I always remove that fibrotic ring as you're talking about. Then I give a purse string, then I bury it with another purse string. And then I bring in waterproofing layers from here and there. Quite often, if it's in the proximal penile shaft, I may open the scrotum and get a tunica vaginalis flap. Because there is a very famous paper by Richter, quoted endlessly in literature, where in his series, one patient needed 15 attempts before the urethral fistula was cured. So it is a bugger to treat. I'm sorry to use common language, but it is very difficult to treat. And you should give it your very best. Use as many techniques as you have, and try and make sure that no patient gets more than 2 attempts at closure of urethral fistula.
Which suture do you
Thank you.
So in my 30 years, first 15 years, I may have used Vicryl, but last 15 years, whether it's esophageal atresia or hypospadias or pyeloplasty, I use PDS. For the esophageal atresia, I will always use 5-OPDS, but I've mentioned in the book, and I know it sounds very didactic when I say it, you see a tiny gap which will not take a 5-O suture. But if you see a tiny gap and it leaves you nervous, slip in a 6-O suture there. So most sutures in the esophageal atresia are 5-OPDS. But there is the odd superior slipped in where the gap is tiny.
Professor Roy Chaudhary, please unmute yourself.
Devesh, I hope you remember.
The line is not very clear, but yes.
He's asking if you remember him. He's the professor at Lady Harding.
Absolutely, remember him very fondly.
Can you hear?
Yes, sir.
Okay, nice now. And had interaction. I even stayed in your Great Ormond Street apartment for 2 days to attend the conference. So I vividly remember interacting with you. Very nice sweet memory. First of all, congratulations on your long professional, very successful career, and excited waiting to see your new book on esophageal this year. This is a academic professional meeting. Just one of our observations is the esophageal pouch. It does play a very significant role in determining the outcome of and it not only determines the gap in there, but also determines the outcome. Just say, we talk a lot about the upper pouch, but it is the lower pouch which is often low, thin, acidic, small cantilever, difficult to take bite. So the kind of determine what in the low pouch. I hope I will be able to publish this soon, and then we'll get on to you and send you.
I'm sorry, we could not hear most of your comment.
He said the lower pouch is the one that determines the outcome.
Could the best
So it's
here?
very atretic and it's very low pace in some cases.
I'm not sure. I think there's some problem with transmission.
We could hear a bit, sir, but about your new technique, we could not hear what you were saying. He said he has a new technique for the lower pouch, which is going to publish.
I'll be delighted to read that report when it comes out.
Thank you for your comments, sir.
Right, thank you.
Dr. Pittu.
Hi, Dr. Devesh. He may not remember, but we were students when we used to come to his outpatients department. I think you were in general surgery at that time. So it was very nice to see. I was watching, you paying tribute to all the senior consultants, Dr. Guleria, who passed away very recently. And one of the things that I would really like to congratulate you on is having gone and set up yourself and achieved so much in your career, as well as your other profession of being a sailor, a captain, a diver, and of course your two kids who have met sometime in the past. I don't have any questions regarding your presentation, but what I thought was very important is the bits of wisdom you've dropped with your sailing. No one takes a photograph of you when you're in the eye of the storm. So it's only when you are in that storm that you face it alone. And most pediatric surgeons are like that. When you're in the eye of the storm, nobody is there to kind of take that photograph and tell you what to do. But when you cross that storm, that's when the photographs come on. So you obviously have crossed those storms and achieved a lot, professionally, personally, and now with your new book. So congratulations with that. You've been a shining beacon for all the young generation that we were there as undergraduates while you were a senior, and your journey and into your professional life in another country and establishing yourself as a professor in the UK is commendable, and I think the younger generations should know about it and should see how much you've achieved on your own. So thank you so much for that.
Thank you, Thichin. It was a pleasure to meet you again after all these years. I remember you very fondly. On a totally separate note, there's an international hypospadias workshop in March in London. So look it up online. There is myself, Warren Snodgrass, Aditi, Peter Kukau, and these are some of the world's best known names in hypospadia surgery. We have all disagreed with each other in the past, but it is nice to see people who have disagreed with each other come together on a common platform and talk about their own individual ways of doing hypospadias. In particular, I'm also looking forward to meeting Warren Snodgrass because you may be aware that he has started doing for proximal hypospadias a 3-stage repair, a stack repair. I'm still not convinced, but I'm going to this meeting with an open mind because it doesn't matter what age you are. I'm 64. There's always time to learn new techniques and see if it works.
I would now request Professor Rajpal, an AIIMS alumnus, professor in RPC Center.
Hello. Good afternoon.
Hello.
And we were friends. He was senior to me. I congratulate you for attaining such a height. And we were together and we used to enjoy a lot. And he has gone outside, but we have stayed inside. And more inside we have gone, more and more we will enjoy. His name, Devesh. Now I know the actual meaning of the Devesh. Devesh is going inside, Dev becoming that thing, he's parting, he's giving. So that is our objective of our AIIMS also. Sarir Madhyam Kalu Dharm Satnam. So Devesh is a very great meaning which has achieved after going to UK and his S-placing there. Thank you, Dr. Devesh.
I always say I left India in 1992, but India never left me. And it's always a pleasure. It's very emotional coming back to India. In the past, I used to come back every year, now maybe every second year. But I hope now as I move into semi-retirement mode for a few years that I come back more and more.
Okay, you may not remember, I am Dr. Rajpal at
course I
present.
remember
Professor. Oh, because we were together for 6 years. Thank you.
Thank you so much. Bhatnagar sir, are you around online? Sir has been there throughout the lecture. He talked to Dr. Devesh also in the beginning. We end with that. Thank you very much. Your comment, Dr. Devesh, how was your journey at AIIMS when you came here and your dreams? Do you think you have fulfilled all of them? And how was your decision when you decided to go abroad? Was it easy? Or
I did not want to go abroad. My heart is in India. But in 1992, as you remember those times, people used to finish their training and often be pool officer for years and years. And when I got an opportunity to do a year or two in UK, I took it. But after that, it was beyond my wildest dreams. Because those days, people came from abroad and were training for 10 years before they became consultants. So when I became a consultant in 3 years, I think I'm very, very happy. But over the years, I've maintained my links, come back here. It's very nice to interact with Prof. Bhatnagar, D.K. Gupta, yourself. Satish Agarwal was a colleague in my time. He's a very dynamic pediatric surgeon in Gangaram, and we spoke earlier this morning. It's always a pleasure, a unique pleasure to come.
Bhatnagar sir, we'd like to hear you. Yes,
Hi,
sir.
Devesh.
Hello.
Sorry, I've been in and out. I couldn't hear all your talk, but I did enjoy your sailing and your diving. I wish I could have done that as well. But, sorry, that's not my cup of tea anyway. But Devesh and I, we go back a long way. I think I was quite a few years senior to him during our undergraduate days. But we've been friends since he decided to join pediatric surgery. And I have funny memories of Devesh. One of them which really strikes out is that I was in England, in London for a year, doing a fellowship in King's, and we had invited Devesh over for a meal, and poor man, he landed up and found a lock on the door, and that was because the night before I had a heart attack and I was admitted in hospital, and we somehow couldn't
couldn't inform him. So that was one of the, I would say, now I can say a very funny incident. But at that point of time, I was fighting for life and death, and the very poor man didn't know about it. But ever since then, I think we've been in touch. I think the last few years we haven't really been able to meet, but it's always a pleasure to meet Devesh, talk to him, and discuss about non-academic things more often than academic. It was nice having you, Devesh. I'm sorry. I would have loved to be there in the boardroom, but just couldn't be there. Okay. I loved your training.
Pleasure to talk to you, sir. And remember, this talk has been recorded online, and there's some YouTube link which Shilpa will send you, so you can always watch it later. And regarding your comment about not learning sailing and all, it's never too late to learn. So,
Yeah. And not at 73. I don't think I'd recommend that to anyone.
We can take you for a ride, sir. Thank you so much, sir. Thank you, Kanika, sir. Any other questions? Anything from anesthesia? You want to ask something regarding preterms? Switch on the mic, switch on the mic.
yeah, I can hear you. Yes, so I think, to be very honest, coming back to medicine, pediatric anesthesia, you need quality pediatric anesthesia to keep your patients with esophageal atresia alive and look after them post-op. And we have such a mind-blowing service at the Royal London. But we are aware that there have been issues around UK and Europe, and sometimes some hospitals have a rule that when an OA top is to be operated, in the younger generation, they insist on 2 consultant surgeons and 2 consultants on each division to be there in paper. And maybe 5 years later, they've got enough experience to become independent.
Thank you so much.
Meet my super senior, with
She's
whom
a
I've
name's
interacted
alumni.
so many times on social media, but I've never had the opportunity to meet him in person. So
Yeah.
just came to see, sir.
Thank you for joining. Thank you all who joined us online, and the video will be there on YouTube. Thank you so much for joining. Thank you, Dr. Devesh Misra. It was a wonderful talk to your adventures, both surgical and in life skills. And I like your message that it's not only surgery. We as pediatric surgeons tend to get so engrossed in our field that we feel this is our life. But there is a life definitely beyond medicine that also needs to be explored and keeps you going when you're near retirement. And after that, also you have life which is forever. Thank you so much. Thank you.